Thank you, Dr. Amer, for this kind introduction. First of all, I'd like to thank Dr. Riam and the organizing committee and scientific committee for this great conference. I mean, job well done. I mean, this has been there for 5 years, and I'm happy to participate every time I'm called upon. Today, I think I'm probably the only surgeon around here. I don't see surgeons. Okay. Tough position to be. I'm a surgeon trying to preach to endocrinologists about diabetes. I don't think people envy me on that, but I wanted to highlight the changes in indications for bariatric, or specifically in this setting, metabolic surgery. I'm going to talk a little bit about why do we need about the history and why we need these guidelines and why we need to update them. So in general, why do we need a guideline? Well, guidelines improve the standards of care. So we will provide a standardized care for every single patient. And what will that translate to for patients? Well, of course, improvement in the outcomes of these patients. Finally, it would help us influence public policy. I mean, when you have guidelines, we can approach policymakers, insurers to help, for example, cover the cost of certain medications or procedures. What constitutes an ideal guideline? Well, first of all, we know that we live in the era of evidence-based medicine, so it needs to be evidence-based. It needs to be free of bias and contains minimal opinion. So instead of saying my experience is 1,000 patients, and no, I need to have evidence. I need to have published papers, and then we have a collection of this evidence. Moreover, we can include best practice data. An important factor is that it should reflect the state of the specialty at the current time. I'm not going to talk about a guideline today and bring studies for 20 or 30 years ago. So this is very important. Finally, we really need to update these guidelines. Bringing a guideline and just leaving it out there for 5 or 10 years shouldn't be the case. Every 4 or 5 years, these guidelines should be updated. So what are the current metabolic or bariatric surgery guidelines? If I ask around, I think, let's say, Yahya, when would you refer patients for bariatric surgery? Oh, okay, sorry. I forgot your institution, sorry. In general, if you ask anyone, the current guidelines are BMIs of 40 with no comorbidities, 35 with diabetes or other comorbidities. If you ask anyone from where these guidelines came, ما حد بيدري. حافظين الرقم, حافظين nobody knows. This is the background of these guidelines. These guidelines were put in place 31 years ago. 31 years ago. I think some people here were born after that. All right? So this was put by the National Institute of Health. They had a consensus development process. This process reflected the evidence at that time. Just for your perspective, it was 14 internists and 1 surgeon, عشان تعرفون يعني where these guidelines came from. So emphasis is on 31 years ago. Again, we talked about the fact that they discussed that 40 or above, 35 with comorbidities. Despite the fact that it was 31 years ago, these guidelines are the ones that are consistently being referred to by policymakers, insurers, hospitals, or even some surgeons when they explain to patients. The question was, are we really too stringent? I'm going to talk about the evidence behind this statement. So, are we actually withholding care from patients? And that's where the need to change. So to put things in perspective, again, these were in 1991. Just to give you something to imagine how far away this was. It was the year that the Soviet Union collapsed, okay? Do you remember that? It's how far that was. It's the year that the internet came into commercial use. Remember that? That was the year. So see, this is how far this was. This was worldwide. What about in Bahrain? This was the year that Desert Storm, the Desert Storm was there. At that time, we were looking for gas masks. Now we're looking for N95 masks. We're still looking for masks, it seems. I don't know what will happen in 10 years, what type of masks we'll look for. So what happened from then and then until now? Keep in mind, in 1991, metabolic and bariatric surgery were complex, one of the most complex kinds of surgeries. they were performed using the open technique. So they constituted a big burden on these patients. Moreover, the anesthetic agents that were used at the time were inferior to what we use now. And accordingly, these patients were susceptible to a lot of morbidities and mortality. So the mortality morbidity rate at that time, because of this factor, was quite high. And the weight regain was quite high. Moreover, there wasn't any standard practice. I mean, it was an infantile specialty. توها مبتدئة. Nobody knows what's right. There were probably 20 types of surgeries everyone's trying to figure out. And we have to admit, yes, there was some sort of human experimentations. People started to do these surgeries on patients to figure out which one is best. Little oversight. The emphasis is, at the time, there were no studies, no RCTs. All the studies that were there are small case series. Just to show you how obsolete the surgeries that were being performed at that time. So one of those surgeries, the third one, is the intestinal bypass. This was abandoned in the 80s. We know that it causes cancer. There are other ones like the Mason, again, abandoned in the early 80s. So all these surgeries were the ones that were being performed at the time. Most of these are out of practice. So these guidelines relied on these types of surgeries. So what happened after that? We came to know in 2002 that obesity, the WHO recognized obesity as a disease. It was recognized as a chronic disease, and then the impact and the effect on the obesity epidemic became more apparent. Moreover, globally, all over the world, the metabolic and bariatric surgery experience increased. We started having bariatric specialty, we started to have fellowships, we started to have large randomized controlled trials. New procedures came into light. And again, this is to highlight the new procedures. So the new procedures that came into light in 1991, for example, is the gastric banding and the sleeve gastrectomy and the bypass surgeries that we are still practicing. Keep in mind, at the time of the original guidelines, these surgeries were not in place. Furthermore, we started doing these with a laparoscopy. So the burden on the patients is much less. Patients come in for a day case surgery. We do the surgery, they go home the next day. They drink water, they do all these things. The anesthetic agents improved. So these surgeries became, started to have lesser impact, lesser complications. So currently, the benefit of these surgeries way outweigh the risks of these surgeries, unlike what was the case in the past. However, despite all these advances, despite the guidelines being old, we are still quoting these guidelines now. Just to tell you about the consensus, as I said, it had a bit of, the one that we talked about, it had a bit of limitations, relied heavily on the BMI. They set age limits. They said this is only for people that, so these surgeries are only for people that are 18 to 55 at the time, and there was no laparoscopy. Surgery was underrepresented. Funny enough, the same people who did this consensus in 91, in 96 they published a paper saying that, literally, some of the material is likely to be out of date and at worst simply wrong, yet we continued to quote it. So what happened 31 years later? Well, from that time until now, the people in the consensus held two more consensuses, the same thing, they did not change. Then the NIH retired the consensus forming body, and they referred the guideline development to the American Heart Association, not surgeons, to the American College of Cardiology, not surgeons, and to the Obesity Society, which was mainly again, not surgeons. So they relied on non-surgeons to form surgery guidelines. And these three societies came in and published a statement. It was not a guideline, mind you. Again, they said that we will continue with the same guidelines. Now I'm going to talk about the two biggest surgical bodies that treat obesity. So one of which is the IFSO, International Federation for the Surgery of Obesity and Metabolic Disorder, 72 nations, 10,000 members. They had a number of statements in the last decades endorsing surgery in class 1 obesity and for different indications, different comorbidities. In the Middle East and Eastern Asia, IFSO had an Asia-Pacific committee that endorsed surgery for diabetics at a BMI of 30. Because what they found is that especially the people from the subcontinent started developing complications at lower BMIs, so they started looking into lower BMI indications for these surgeries. What about in the United States? In the United States, the ASMBS, American Society for Metabolic Surgery, has around 4,000 members. Again, very stringent, evidence-guided body. Over the last decades, they started publishing guidelines endorsing surgery for lower BMIs, especially in class 1 obesity. Moreover, they started looking at newer indications, the effect of obesity on cancer, doing these surgeries, and the effect of surgery on NASH. Was it only the surgeons that started looking into changing the indications? No. Even our friends, the endocrinologists, I think a large number of you guys probably are aware about the DSS Summit, the Diabetes Surgery Summit, which was mainly run by endocrinologists. Around 48 international society, the majority were endocrinologists, said also that metabolic surgery should be considered for people with type 2 diabetes and BMI above 30, or even, and these levels should be dropped by 2.5 BMIs for people from Asian descent. Again, these were recommendations, still did not constitute a guideline. So, comes the year 2022. Both the American body and the international body came together and said, we have high need to update these guidelines. So they sat together in the span of over 2 years, around I think 100 experts gathered thousands of studies to come up with these guidelines. So what changed? When they looked into the available literature right now, they found that sleeve gastrectomy and bypass surgery constitute around 90% of the procedures performed worldwide. They estimated around 700,000 bariatric surgery worldwide. In the Gulf area, we're talking about around 10,000 procedures being performed in the Gulf area. Moreover, the lap band and vertical banded gastroplasty is out of scope. So what about the indications? Well, first of all, they looked at the old indications and they expanded them. So remember what we said, 40 without comorbidities, 35 with comorbidities. So what they did now is that they said there is enough evidence to say that this metabolic or bariatric surgery should be recommended for 35 with no comorbidities and 30 with comorbidities. Diabetes may be one of those comorbidities, but then we're talking about hypertension, dyslipidemia, and others. Sleep apnea, I mean, these are others. In patients with diabetes, they dropped it into 27. Furthermore, based on the studies provided by the Asia-Pacific population, they dropped all these previous marks by 2.5 for people from Asian descent. Again, because of the clear, unequivocal evidence that highlighted the higher prevalence of complications from diabetes at a younger age with a lower BMI when compared to the Caucasians. Moreover, when they looked at the age limit, they expanded the age limit. Remember what I said, 18 to 55. So now it's indicated for any age in pediatrics, as there are operations that were performed as low as 2 years. This is not the normal. The normal, I would say 9 to 11, but as low as 2 years. And the indications were, I mean, you know how pediatricians love their percentiles, so I cannot make sense of this, but BMI more than 120 of the 95th percentile, or BMI above 140 with comorbidities, or a BMI above 140%, the 95th percentile without comorbidities. And when it comes to the geriatric age, they said even above 70, these surgeries can be performed for patients above 70, provided they have good physiological reserve. So if you're looking at a 70-year-old who's walking, going to work, conducting his life normally, that's fine. But then if you look at the 70-year-old that's in bed, not moving, then this is a problem. So it all depends on the physiological reserve rather than the age number. Furthermore, there were new indications that were added based on the benefit of bariatric surgery. So there were a lot of people that needed joint replacements, and obesity was a risk factor of poor outcomes for these joint replacements. There are people that needed major umbilical hernia repairs. Obesity is a huge risk factor for these patients. And finally, we know, I mean, Dr. Basil is here, I'm not going to preach about the higher risk for failure after renal transplant with obesity. So surgery is bariatric surgery is indicated for these patients as a bridge to these other surgeries. So we do the bariatric surgery, patient loses weight, they do this other surgeries, therefore the outcome improves. Furthermore, surgery is indicated in high-risk patients. These are patients that we used to be afraid of operating before, but all the long-term big data studies showed the safety of these surgeries. So people with super obesity, so above 60, so we're talking about people probably that are 250 kilograms or more, surgery is safe for them. People with cirrhosis, surgeons used to run away from cirrhotic patients. The moment you tell me cirrhosis, I'll say, yeah, I'm not touching. So now we know that these surgeries are actually safe in this patient subpopulation. And patients that are in need for LVAD, I mean, these surgeries help as well. So in conclusion, this guideline expanded the indication for bariatric and metabolic surgery in order to give more access for these patients. So how does the old guidelines compare to the new? Again, on the left side, you will see the old guidelines that relied heavily on opinion. There was a bit of experience in it, very little science, versus the new guidelines that are purely science, a little bit of best practice, very little opinion. Again, if you look at this, this summarizes the whole comparison. Old guidelines looked at open bariatric surgery, whereas now we're doing laparoscopic, robotic, or even endoscopic surgery. Old guidelines, we mentioned expert-based, now it's evidence-based. Old guidelines developed by non-surgeons. These are surgical guidelines developed by non-surgeons. Now we have the guidelines are developed by surgeons in collaboration with endocrinologists. The old one looked at small serieses. Now we have huge data. There are registries with tens of thousands of patients. So a lot of multi-centric studies, a lot of meta-analyses. Old guidelines looked only at weight loss. Now we are looking at metabolic and bariatric surgery. We're looking at metabolic outcomes. Age limits are removed, and surgery is now indicated even as low as class 1 obesity. At the end, I would like to say that the old guidelines are a barrier for patients to access these surgeries. They prevent access to one of the safest, most effective, most studied operation in medicine. I know a lot of you will say, but I have the studies to show this. Currently, there are hospitals that are performing bariatric surgery more than all the general surgeries put together. So we say that we put the old guidelines into retirement. So in conclusion, I mean, it's the same thing. I mean, the current guidelines are outdated, or the old guidelines. So now we should adopt the newly developed guidelines as the standard, and we need to retire the old ones. These barriers need to be removed. We need to increase the knowledge of these new guidelines to policymakers, to healthcare providers, hospitals, and insurers. Thank you very much, and I'm pretty sure we will have a very fruitful discussion. I'm waiting